Good morning, everybody. And at the outset, I would like to thank Dr. Neeraj and the rest of the organizers for giving me this opportunity to be sharing some of my thoughts about newer cell counter parameters in hematological diseases. And it's interesting the way the world has changed. I bring you warm regards from my hospital, BL Kapoor Hospital, which is in the heart of Delhi. And I must mention upfront that the views which are being presented, a lot of them are perhaps based on my personal experience and may not have direct correlation with anybody specific. Now, the world has changed. We know that from something where somebody would, sneeze and we would say, "God bless you." We've reached a stage where we feel scared and just want to move away from one another. And thanks to this one small little virus or the small particle, which has changed our lives so much. So while this was happening, a lot of things have been happening in the world with respect to the hematology analyzers and automation in hematology. This is just to give you a brief overview of how the evolution of hematology has happened over the last so many years, which includes a change from the microscopy, light scattering, looking at impedance measurements, looking at fluorescence-based flow cytometry, and a lot of it was actually shown by my colleague, Dr. Jasmita, in her presentation just recently. So there's been a huge plethora of change, from the way the blood cells were counted about more than 300 years ago to where we are today. And a lot of the credit to this actually goes to a set of people, which I'm going to show you, to get the hematology analyzer from where it was to a proper thoroughbred machine, which we are dealing with today. Now, the entire credit for this goes to these two gentlemen, the Coulter brothers, who were actually the ones who gave us what we call the Coulter principle. And I'm sure a lot of you would have known about it. This was something which was called a Wallace's plankton detector many, many years back. And this detector was actually important for us to understand that we would find out whether the planktons are there in the, during the Second World War. Eventually, post the Second World War, these guys went across to the patenting authority and started asking them to give them a patent vis-a-vis the aperture which they had made through which they were wanting the cells to pass. And interestingly, if you would notice, the aperture was made out of this thin film using a needle and the thread. And this particular aperture is what they wanted a patent for. Now, all that is history. We all are very clear and aware about the fact that the electrolyte solutions allow the currents to flow and pass through them, and that's what the premise was. And you would ensure that they would pass through a specific small little hole, which would allow the cells to pass. Depending upon the cell size, the pulses would differ, and you would put them on a graphic determination, eventually getting the plots. And the Coulter principle will give you, just as the way which is shown here, the particles will pass through, and based on the particle size, aperture size, and the particle volume, you would be able to get your graphic data. Now to this, at the same time, the FLOWCELL technology came in, and we are all aware about flow cytometry, how flow cytometry has taken over a lot of our work vis-a-vis the hematology analyzers. We have moved on from the typical impedance-based technology to a flow cytometry-based technology. And in most of the analyzers, there's an amalgamation of both the technologies to ensure that whatever data we get out of it makes a lot more sense than what we were making previously. And we are all aware of this particular aspect where a laser light is used on the cells, which are either dyed or not even given any dye. And based on the scatter properties of the forward light and the side scatter fluorescence, you are actually able to differentiate between various cell types. Now, this is a typical scatter plot which you get from a hematology analyzer when you are having an analyzer with a fluorescence-based technology. What is shown in the first plot over here is your differential scatter plot. You're also having what is called the baso channel or the basophil detection channel, where you also find nucleated red blood cells in the NRBC channel. And of course, you have a reticulocyte channel where you're looking at the red cells and of course the platelets at the same time. To add to this, you also have conventional impedance-based technology, which is based on the red blood cells and the platelets passing through the usual electrical current. So all these together then give you a better idea and better information with respect to the various cells which are passing into the analyzer. So now let's look at advances in the hematology analyzer vis-a-vis the RBC counts. So if you look at the analyzer that we have on our place, we are using an analyzer from Mindray, which is again a fluorescence-based analyzer where there are two distinct dyes used, the FR dye, which is the dye which stains the reticulocytes, and of course we have a diluent which ensures sphering of the red blood cells. And this entire concept eventually gives you the reticulocytes, which you are able to pick up from the hematology analyzer itself. Now, one very important aspect to be remembered when you're analyzing the reticulocyte on a hematology-based analyzer, you would notice that there will be a reference reticulocyte counting, which will be done using a fluorescence flow cytometer, and you will have the analyzer-based automated reticulocyte counting. So if you compare both of them, there will be a difference between two because you will be able to observe that you will have variability in the angle compared to the reticulocyte count. So obviously, when you are trying to compare them at a higher value, they may not be comparable. However, when you go to the low values, the comparisons are far more precise to each of the analyzers. Now, the reticulocyte counting is primarily based on the simple fact that there will be sphering, and then you will dye them out, and the amount of fluorescence intensity which you get from them is dependent upon the material which is present within the cells of the genetic material or the RNA material which is present within them. And subsequently, you let the cells pass through a fluorescence flow cytometer in a flow cell, and you put a laser source across them and get your forward scatter and the side scatter, just like a typical flow cytometry protocol, and you are eventually able to get the data from them. Various analyzers call it based on their specific, the technologies that they use. And in this particular case, the technology that is used is what is called the SFQ, which is nothing but scatter and fluorescence, and of course, a three-dimensional analysis of all the three together. And what are you able to get eventually is the red blood cells. And of course, with the red blood cells, which are mature, you are able to get the other red cells, which are your reticulocytes. And all these reticulocytes will have various fractions which are available. This is the range that we have developed in our system. In addition to that, in the same channel, you're also able to pick up your platelets. And of course, what Dr. Jasmita did show us in one of her slides was the fragmented red cells. And we'll touch upon a little bit in my subsequent slides. So the first important aspect is the spherization of the red cells. And the red cells can be of various shapes and sizes, and you make them go through a sphering system. In this particular analyzer, the dye which is used is the VR diluent, and that helps you to make the cells into spherized balls. And eventually, some of the cells will escape, something like sickle cells, which will be picked up in the reticulocyte channel. So when you look at the RBC methodology, this methodology allows you to look at the cells at the low angle scatter, wherein you pick up the volume, and at the high angle scatter, you're able to pick up the hemoglobin concentration. And eventually you plot them against a scatter plot, wherein you are plotting both of these, the angle scatters, the low and the high angle scatters, and detecting them basis on their expression of the scatter properties. Once you look at the RBC scatter plot, you are able to look at cells which are condensed in the form of a scatter, a dot plot. And eventually, if you look at the dot plot at various levels, looking at the volume and the hemoglobin concentration, you are actually able to differentiate between various cell types like hypochromic, hypochromic, microcytic, macrocytic, and of course the normocytic, normochromic red cells. Now, with this kind of activity which is happening, you are able to differentiate all the cell types, and subsequently you're also able to look at the different disease states. And these are very distinct from the binary dot plots which you otherwise get with respect to hemoglobin concentration as well as the RBC volume. So in a similar parlance, from this analyzer as well, from the analyzer that I use in my center, we are able to get various information, which is helping us to differentiate between various cell types. Let me just show you a few illustrative cases to put the point across. So if you look at this particular scatter plot, which you're seeing from the RBC volume versus the hemoglobin concentration, what you're obviously able to see is that the cells have fallen down into the microcytic area. And of course, the hemoglobin concentration is also decreasing to a little extent. And compare this to the normal one. Okay, so you're looking at a microcytic hypochromic iron deficiency anemia kind picture, and this is how the shift of the hemoglobin curve, the RBC curve has happened to the left, indicating that you're dealing with an iron deficiency anemia. Similarly, if you look at this particular plot, you don't see much of a difference. This is like very well within the normal range of the plot. And again, when you look at the hypochromic microcytic plot, you're able to see that the cells have fallen down significantly. Now, I'm sure you would have seen such cases in your practice. If you see this particular plot, you're seeing the red cells which are right in the center of the plot. And in the center of the plot, compared to this, you have a very distinct population of red cells which are having a higher volume. And these are nothing but macrocytes. And again, when you see the RBC scatter plot, RBC histogram, there is a very distinct shift to the right on the histogram itself, clearly indicating that you have macrocytes. And if you look at the history, it's a 35-year-old male, a known case of HIV on therapy, which is indicating that this particular patient probably is giving you what is called the drug-induced macrocytosis or the non-megaloblastic macrocytosis, which happens in HIV. Just to give you a clear indication, this is how it used to be in a normal case, whereas this is how it is happening in a non-megaloblastic macrocytosis. Another case where there is a 40-year-old female with fatigue and mild yellowish discoloration of the sclera for the 2 months. You see this is a normal scatter plot which you get from the RBC channel. And look at this particular channel plot where you're having a very distinct spread into the macrocytic area. And with this, the patient was obviously showing a scatter plot or the histogram, which is showing very distinct shift to the right. Again, a classical case of megaloblastic anemia. Here you are able to see how it was. Another case, a normal one, and here you will distinctly see two distinct populations of cells, one which is the hypochromic and the microcytic one, and of course the macrocytic ones here, whereas also you have a normocytic normochromic component. All the three components together are clearly telling you that you're dealing with something which is like a dual deficiency anemia, which is also seen in the RBC plot like a camel hump, a double camel hump, which you're seeing in this particular case. So this was a case of dual deficiency anemia. Now, just to give you a comparison of all the three, you have a non-megaloblastic macrocytosis, you have a megaloblastic anemia, and of course the dual deficiency anemia, which you see in these three scatter plots very evidently for all of us. Now, there was a point which Dr. Jasmita did talk about in her presentation where she talked about the fragmented red cells. There is a very distinct article about it, which is, in fact, the guideline which is about it in the International Journal of Laboratory Hematology. But what's very interesting is this has come from the reticulocyte channel. And in one of the analyzers, one of the earliest analyzers to pick it up was the Sysmex analyzer, which is on XE2100. I had some experience of working on it in my previous place of work. And if you look at this particular plot, what you're able to see, you have a distinct red blood cell component. And of course, I did show you earlier that you have the reticulocytes here. And this is an area of fragmented red cells. Initially, they had put only a single gate in this area. Now they have divided them into further sub-gates because the gate 1, which is the lowest gate here, gives you the far more prominent fragments. Otherwise, these are relatively smaller fragments, which can also be seen in iron deficiency anemia. And you compare it with the total RBC gate, which includes the entire gate from here to here, and gives what is called the fragmented red cell counting. In fact, if we look at the recommendation which has come for the international recommendation for the identification and quantification of schistocytes, a very distinct point which they want to make, and I have put it across here, is that automated counting of fragments is recommended by ICSH, and it could be complement to the microscope. Of course, issue is that we need to validate it further in the research settings where we would be able to prove that it has a high predictability. However, one very important aspect to note is that it's got a very high negative predictive value. That means if the fragmented red cells are not found in the report from the hematology analyzer, it's unlikely that you will find it on the peripheral blood film. Now let's look at the advances on the hematology analyzer vis-a-vis the platelet counting. Now, I'm sure all of us have this problem with respect to platelets the moment the dengue season is here, and this is where we are today. We have the dengue season out here. Life would be very simple if we have platelet counting the way it is seen in this particular graph here. We are able to get a very distinct and a beautiful downward slope, and there is a very distinct gap between the platelets and the red cell graph, which is going up. Life would have been very nice if this is how it would have been in all the cases. However, in real life, this is not how it happens. We have both the possibilities wherein we have the red cells falling into the platelet region or the platelets falling into the red cell region. And that's what gives us a big problem in counting the platelets. This particular aspect was obviated by something called the optical platelet counts, which are otherwise also called fluorescent platelet counts. People like to call it fluorescent because they have a very specific dye now vis-a-vis the other competitors, and therefore a fluorescent platelet count where they're claiming that it is a better platelet count even conventionally from the previous optical counts which were available. Now, what is noteworthy to note is that this particular aspect happens in what is called the reticulocyte channel. And within the reticulocyte channel, you have these platelets, which are picked up separately. You know that these are the red blood cells. These are your reticulocytes. And of course, the fragmented cells, which I talked about in just a minute back. And now we have these platelets, which are lying over here. And you are able to distinctly differentiate the platelets from the red cells very clearly. And it is even professed in many places that this optical count, or the fluorescent platelet count, is a better platelet count compared to what we see in an impedance platelet counting, especially when there are enough number of giant platelets in the picture. So if you look at the optical or the fluorescent platelet counts, the important aspect of the platelet count in this area will be whenever you have an overlap between the graphic representation on the impedance part of the platelets and the red blood cells. A very interesting parameter which comes from the optical platelet counting is this particular one, which is called the immature platelet fraction. And this immature platelet fraction actually suddenly has become something which everyone wants to have in its kitty. So if you look at these are your normal platelets, and of course, these are the microcytic red cells, as well as the fragmented red cells, and the large platelets over here, which are called the immature platelet fraction. Importantly, the immature platelet fractions also happen to be useful, as well as the optical platelet counts happen to be useful, especially in cases like what we call Harris syndrome. If you look at this particular case, the platelet count, the person from East Indian origin had a platelet count 134,000, was basically meant for donating blood in the blood bank, and eventually on the optical platelet count it turned out to be 162 and was eligible to give the blood within the blood bank. Now, I always try to show this picture. This is a picture which I have taken from my friend, Dr. Kunal from Hinduja Hospital, who in one of his presentations showed immature platelet fraction. And that point of time, I actually did not have IPF available in my lab. And he showed this particular picture where he showed an Onida TV advertisement showing that IPF is something like no neighbor's envy and owner's pride. And trust me, it was an envy at that point for me as well. And eventually I got this immature platelet fraction on board and we tried to work on it. And this is how the immature platelet fraction actually started giving us a lot of information, which was helpful not only in our routine practices, but especially in dengue. I'll just show you a few of the cases where IPF becomes extremely important. For example, when you have a low IPF, you are basically dealing with something which is affecting the bone marrow directly. And when you have a high IPF, it is basically indicating that marrow is regenerating or marrow is producing platelets which are which are getting destroyed in the periphery. You have to develop your normal range, which most of the people do in their respective places. In our hospital, our range is 0.6 to 8.0 on our analyzer. And just to show you this one case, which is a case of dengue, this was shared by my colleague, Dr. Tina, where the platelet count was low and the IPF was high, indicating that the marrow is trying to produce platelets. And therefore, the parameters, what we did eventually was did a study. In fact, she also published one of her studies from Hinduja Hospital, which has been published and is available in the International Journal of Laboratory Hematology, wherein the group went on to say that the evaluation of immature platelet fraction was actually indicator of platelet recovery in dengue patients. And this is how the entire thing was panned out. Just to show you quickly, you would monitor platelets and you would also monitor immature platelet fraction at the same time. The moment the platelets start falling down, the immature platelet fraction starts going up. And the moment it starts getting stabilized, that is the time when the platelets are just around the corner and they're going to go up. And in fact, in this particular article, they went on to say that the moment your platelet count stabilizes, the IPF stabilizes, since the platelets are going to go up, you do not need to do any transfusions of platelets. And this eventually actually helped a lot of patients. So IPF becomes a very important and a potential tool for predicting platelet recovery in dengue patients. And they also had professed about the 10% single value or indicative of platelet recovery, which eventually was negated by our friend, Dr. Singh from Suri Path Labs. Now, let's look at a few parasitic diseases wherein hematology analyzers have started to play a role. For example, if you look at this particular graph, this particular plot, which has come from the hematology analyzer, it really clearly tells you about the infected red blood cells. And in fact, infected red blood cells certainly have become a parameter which a lot of people reckon with, especially in malarial parasites. For example, this is a case of malaria wherein you found this very interesting pseudo-neutrophilic population, which was over here. You can also have pseudo-eosinophilic population in some of the analyzers, and this has also been proven to be a possibility of infected RBCs. And basis on algorithms which are developing within these analyzers, you're actually even able to quantify them. And this particular patient's peripheral smear eventually showed us the presence of both the gametocytes and the chysons of Plasmodium falciparum of vivax, and malaria was detected in this particular case. Another case where we're looking at a case, who was having thrombocytopenia with fever, and at the same time, the analyzer had highlighted the presence of atypical lymphoid cells, of course, fragmented red cells as well, and there was some abnormality in the platelet histogram. What is very obvious is that you have this very distinct lymphoid cell population, which is very distinctly separated from the basal lymphoid cell population. And this, the moment you see this kind of a picture, it is kind of reminiscent with having a typical figure of eight appearance that you're seeing over here. And the moment you see this kind of a picture on this kind on an analyzer which is actually looking at the lymphoid cells, you are almost sure that you're dealing with something which is dengue. Of course, there is always an overlap where people will talk about high fluorescent cells which can be found in plasma cells, as well as some abnormal lymphoid cells of lymphoma. However, the characteristic figure of eight appearance, which is seen in a typical dengue fever, is very characteristic. So this was a case of dengue, and in this particular case, we found these atypical lymphoid cells which were present in the peripheral blood film. We had also done a study in our center using various parameters to predict dengue, and what we found that out of all the parameters that we used, whether it was the platelets, the eosinophils, the HFCs, etc., the high fluorescent cells, which were nothing but the lymphocytes or the reactive lymphoid cells, both in percentage as well as in terms of the absolute values, gave the highest predictive value of detecting dengue in patients. We also went on to do a study wherein we proved that these high fluorescent cells actually are able to predict whether the patient is going to be recovering with respect to platelet or not. And if you look at this particular graph depicts very clearly the falling platelet counts and the rising, these high fluorescent cells percentages. What is important to remember is that as the high fluorescent cells percentages keeps on going up, the platelet counts and they are going down. The moment it jumps beyond a basal value, which is either 3, 5, or 7 times of the basal value, we are able to predict that this person is eventually going to recover with respect to the platelets as well. This is a very interesting thing, white cell actually showing you a recovery of the platelets. And we found that with the peak HFC, you are almost able to detect in about nearly 95 to 98% cases the recovery in most of the patients. And with the jump, almost 90% of the cases we were able to predict within 24 to 72 hours. And what do you mean by jump? You're looking at within the base value of zero point 0.4, you're looking 5 times, 0.9, 4 times, and 1 to 2, 3 times. This is how we defined a jump. We also went on to show this demonstrate this in one of the posters in the International Journal Society of Laboratory Hematology meeting just a year or two back. Now, my talk would not be complete when I'm talking about parasites, especially in the era of COVID, because COVID happens to be an important aspect where hematology analyzers certainly seem to be playing a very interesting role. Now, if you look at the plots up here and down here, you will really not make it might not make a huge difference to your understanding in the whole aspect. But what is important to note is the presence of lymphocytes or the absolute lymphocyte percentage, and lymphopenia happens to be something which is an important data that comes from the analyzer. It's also important to note that when you're looking at the neutrophil to lymphocyte ratio, the NLR ratio also gives you a very important information about the prognostication of COVID-19, and the data is still emerging. We are also working on it in our center. It's interesting to also note that there can be partial myeloperoxidase deficiency, which has been seen in some of the cases of COVID-19, especially in this particular analyzer where the MPO is used as a methodology of identifying cells. Just to show you this data, which is already published, and a little bit of it is still in the process, even in our center, you will observe that you're looking at the presence of, the neutrophilia, which happens early in the COVID-19 disease, and of course the lymphopenia, which happens at the same time. So significant lymphopenia actually starts determining the disease severity in a particular patient. In addition, this particular parameter, which has been looked at by the Mendre guys, where they looked at the NLR and the RDWST ratios, and they found that more than 1.06 is indicative of high probability of severe deterioration, and when it was less than 1.06, it was a better disease state. So if we look at COVID-19, the utility of analyzers, we still do not have a very specific parameter, but lymphopenia happens to be something which you will be able to pick up from the analyzer. You will also combine it with CRP and other biochemical investigations to suspect and prognosticate. And of course, NLR, RDW, and lymphocyte, absolute counts with RDW seem to be promising. However, the data is still, evolving in that area. Now, advances in hematology analyzers and providing a helping hand in other areas. Just to show you, body fluid enumeration is something which is always a difficult task, especially when you have to charge the chamber and you really are in a difficult state to actually look at them. The body fluid enumeration on hematology analyzers is able to give you, you quick information about the cell populations within the body fluids, which include CSF, pleural and peritoneal fluids, and of course the synovial fluids, etc. There are various reportable parameters which are already available on our body fluids, which includes the WBC differentials, including the mononuclear cells and the polymorphonuclear cells, the total count, and of course the RBCs from the RBC channel in there. There are also many research parameters because they are still in evolution, and perhaps probably in maybe another 6 months to a year or so, this should become much better where we are. The last and the final thing which I'm going to talk about is the future of automation in hematology, whether it's a dream or reality. We need to remember what's happening is that there are many novel methods under development. There are many contrasting agents which are being used, especially to have multiplexing capabilities. You're also looking at smaller volumes of blood being used, and also developing portable and in vivo blood counting machines. And it's important to remember that quantum dots and rare earth metals are now becoming very important, especially in terms of diagnostics of the hematology analyzer. And with each passing day, we are believing and we want to develop quantum dot based technology to give quicker results and more precise results. Need for portability, we understand that, especially in the COVID has made us realize that, we need to have availability of testing in the remotest possible villages, and therefore the need for automated counters which are portable and can be made available in the disaster areas and the remote areas is also happening parallelly at the same time. There is also miniaturization of flow cytometry based cytometers or measuring devices for measuring cells, and in fact, chip based impedance spectroscopy for WBC differential count. And of course, even a four-part leukocyte differential count is already happening. And it's all happening in a very small biochip, wherein you are able to actually put the small drop of blood, and it's able to actually give you the entire counting within the smallest possible way. Now, digitization of hematology is also happening parallelly. We all aware of television kind of instruments where we are able to digitize the imaging processing, and eventually we are able to actually get hold of the information within the microscopy from a distant area, and we can eventually also give the diagnosis based on this. These are just some of the pictures from the television. And we are also having very interesting resurgence of the image-based cell counters, wherein we just take a sample, allow the sample to be dropped onto a blood film, onto a smear, and eventually the smear is being, scanned and put onto a computational analysis. And based on the smear itself, the imaging of the smear, we're actually able to give various cell types, including the hemoglobin levels, the platelets, etc. And this is also happening currently. In fact, one of the analyzers, which was professed by the company called Roche, was developed called Bloodhound. And though it's not readily available still, but this is something which is happening parallelly. Also, a high throughput lens-free based blood analysis on a chip, which I already mentioned a little bit, is also parallelly happening. Now, what would be best would be probably an in vivo automated blood cell counting, where you would not want to remove the blood from a vein of an individual and potentially test it. Now, this potentially non-invasive and continuous monitoring of patients is possible. There is something which is already being developed and by Abbott actually, and it's currently in phase 2 of testing, and hopefully in due course of time, we will be able to see it in better state as to how it will affect us. Of course, it's also important to realize that there are many challenges in this, which includes the poor optical conditions, especially when the patient is having a lot of fat in their arms, where it's impossible for you to actually penetrate through that and get the information. A lot of other newer technologies are in picture, which includes optical absorption, elastic scattering, ultrasonographic identification, photoacoustic methodologies. I'll not get into details of this because primary reason is that I myself am not very well aware of what is really happening in this area, but hopefully in due course of time, things will become better. So if I will end with one last statement. I have no idea really what's going to happen, but I love this way. We really did not realize that we'll be having a conference the way we are having it today, and life has really changed so much. So I wouldn't want to predict. However, I would really have a positive attitude, and I'm sure the analyzer is here to stay, and it's going to give us far more important information, and maybe in a quicker manner in due course of time. Thank you very much for your kind attention.